That recording. Okay, that recording has begun. So again, welcome. This is the Preventing Injuries in Children with Autism webinar, and it is sponsored by the Children's Safety Network. I do want to thank our funding sponsor for this. That is the Health Resources and Service Administration of the Department of Health and Human Services. So we appreciate their support and their continued support in these types of webinars for all of you. Next slide. I'm going to hand this over. There's a few technical announcements to make. So before I introduce the speakers, I'm going to hand it over to Kristen. Kristen?
Hello, everyone. Thank you for joining us today. If you can, it's best to join audio via your computer. And if you do experience any audio issues, you can dial a phone number found in the Zoom invitation and mute your computer speakers. You are muted and you will remain muted for the remainder of the webinar. If you do have any questions, you can use the Q&A button found at the bottom of your screen to go ahead and ask those at any time throughout the webinar. We will have a portion at the end where those questions will be answered. This session is being recorded and we will post the recording along with the slides to our website within 1 week of today. If you need to use closed captions, you can view those by clicking the CC button at the bottom of your Zoom screen. And any resource files and links will be shared in the chat to all of you if necessary. And now I'm going to hand it back over to Judy.
Great, thanks, Kristen. All right, everybody, I just wanted to introduce myself. I'm Judy Qualters. I'm your moderator for today, and I'm the director of the Division of Injury Prevention at the Centers for Disease Control. And I'm an active member of the Child Safety Network Alliance. So I want to welcome our presenters and introduce them to you. We have 3 great speakers for you today. Dr. Sarah Tinker is an epidemiologist or a health scientist and a senior scientist in the Child Development and Disability Branch at the CDC. And in this role, she provides scientific support to research, surveillance, and programmatic activities focused on serving the needs of children with developmental disabilities and their families throughout their lifespan. Ms. Shericka Harris is a health scientist in the Division of Injury Prevention at CDC's National Center for Injury Prevention and Control, and she works to prevent drowning deaths with research focused on drowning prevention in children in autism. And finally, Jarbing Chen is an assistant professor at UML Department of Psychology. And as director of the UML Pediatric Injury Research Lab, Dr. Chen's research focuses on reducing injury-related health and healthcare disparities among neurodiverse children and adolescents. And of course, on the screen, you see Dr. Yang Wang. She helped to put together this presentation today, but unfortunately could not be with us. So with that, I'm going to hand it over to Sarah to kick us off.
Thanks so much, Judy. I'm going to start the presentation by just giving a quick overview of autism spectrum disorder. Next slide. So autism spectrum disorder, go ahead and click one more, sorry, is a developmental disorder that's characterized by deficits in social interaction and communication and the presence of restricted and repetitive behaviors. Click. Diagnosis is a multi-step process. There is no single medical test that can definitively diagnose autism, and it's a fairly complex process where clinicians look at developmental history and behavior in order to achieve a diagnosis. Next, one more, there we go. So there is, sorry, back, there we go. So there is no one cause of autism. There are a few environmental risk factors and genetic risk factors that are known, but largely the causes are unknown, and it's thought that it's probably a combination of environmental and genetic factors. Now, next slide, please. Thank you. So the prevalence of autism in the United States, the most recent estimate is 1 in 36, or 2.8% of 8-year-old children, and that was using data from 2020. This estimate, which is probably the most quoted estimate that's given, is based on tracking within 11 communities that are part of CDC's Autism and Developmental Disabilities Monitoring, or ADAM network. Next slide, please. And as you may have heard or be aware, the prevalence of autism has been increasing over time. So this plot shows data from ADAM over the past few years, and it shows that there has been a fairly dramatic increase over time. We think this is almost certainly due to increased recognition of the condition and diagnosis of typically children with a little bit milder symptoms, and that is what's leading to this increase over time. Next slide, please. And click. So autism can be reliably diagnosed by age 2 years, but click. Diagnosis typically occurs later, and it can depend on many factors. The average age of diagnosis is a tricky statistic to look at because there are so many adults who are now being diagnosed for the first time that it can make it look like there haven't been advances in early diagnosis, but really that's what we're seeing. So if you click one more time, we've started to look at cumulative incidence of diagnosis so that we can get a handle on when kids are being diagnosed. And we see that they really are being diagnosed earlier. So children in the blue, the 4-year-old age group, they are more likely to be diagnosed earlier. So that's a good thing. Earlier diagnosis is better for helping to support these kids with autism and their families. Next slide, please. Thank you. ASD is four times more common among boys relative to girls. So using those same 2020 ADAM network data, we saw a 1.1% prevalence of autism among 8-year-old girls and a 4.3% prevalence among boys. So definitely much higher in boys. Next slide, please. And I think it's important everyone understands that autism affects children of all races and ethnicities. So initially, it used to be we saw a big disparity in identification of kids with autism, and it was much more prevalent in white children. But this trend, we've seen a real change in it over the last few years. And now you can see the prevalences are pretty similar and even higher among um, some of the minority groups. And we think this is probably a positive sign, that it means that these groups are getting better access to diagnostic uh, services, which is, of course, the first step in getting the services that they need. Next slide, please. So many people with autism also have intellectual disability. It is not a core trait of the condition, but it is an important co-occurring condition. And some people can use it to give an idea of quote unquote severity of autism, because we don't really have standardized or meaningful measures of severity. So in the ADAM data, IQ was missing for about a third of kids, but among the kids, the 2/3 of kids for whom we had ID data, we saw that about a third had IQ less than 70, so we would consider that to be an intellectual disability. And then about a quarter had IQ in the borderline range. So that's just something important to keep in mind with this population. And then the next slide, please. So profound autism is a more recent and highly debated concept that is trying to capture a meaningful distinction between people on the autism spectrum who might need more support. So this is defined as being nonverbal, minimally verbal, or having an IQ less than 50. The reason why it might be important to identify children with autism with these additional characteristics is that this group has been shown to be more likely to have self-injurious behavior, have epilepsy, and require around-the-clock supervision. An estimate using 2000 to 2016 Atom Network data estimated that about a quarter of kids of 8-year-olds with autism would be considered to have profound autism. In addition to these descriptors of kind of the severity of autism, it's also important to know that there are a lot of other conditions that more commonly co-occur among kids with autism. So they are 4 times more likely to have hearing problems, 7 times more likely to have vision problems, 7 times more likely to have language delay, 10 times more likely to have ADHD, and 14 times more likely to have motor delay. And this particular study was among kids 2 to 5 years of age. Next slide, please. So why this all is important to think about in terms of risk for injuries is that one particular characteristic that we see a lot in children with autism is wandering or elopement. And this is defined as leaving a safe area or a responsible caregiver, and it typically involves situations where a person may be injured or harmed as a result of the wandering. So children with autism may have challenges understanding safety issues and communicating with others. Next slide, please. So data from a CDC study called the Study to Explore Early Development, or SEED, looked at wandering. Again, this would be among 2 to 5-year-old children, and found that compared to the general population, um, that children with parents of children with autism much more frequently reported wandering of their child. So 60% versus about 12%. And then when asked about frequent wandering, so not just the occasional loss at the grocery store, but something that is a frequent occurrence, it was reported by about a quarter of the parents of young children with autism versus only a small percentage, 2% of the general population parents. Next slide. So another study, or actually this is the same study, compared to a population sample, children without developmental disabilities, including wandering, was 3 times more likely among children with autism, but also 3 times more likely among children with attention deficit and hyperactivity problems, and 2.5 times more likely among children with very low developmental level. So something more common in kids with autism, but also something to think about with kids with all sorts of different developmental disabilities. Next slide. So this is the different study, and it is a little bit older than I would prefer, but data from a parent survey of children with autism aged 4 to 17 years showed, can you go ahead and click? There we go, that 53% of children who eloped were missing for long enough to cause concern. 29% of parents reported that their child attempted to elope multiple times per day, and 35% of parents reported that their child attempted to elope multiple times per week. And when the children were missing, it wasn't for short amount of times. The average was 41.5 minutes. So you can imagine that's very stressful for these parents and puts the children in a dangerous situation. And then the last stat I think I'll present is that data from that same survey showed that when there were close calls among children with autism who eloped, 65% of the time there was a close call with a traffic injury, and 24% of the time it was risk for drowning. So those, definitely those are the things we want to be paying attention to with this issue. I did want to just quickly point out that it's not just autism that can be associated with increased risk for injury. For example, ADHD has characteristics where they're trouble paying attention and/or controlling impulsive behaviors, which can lead to careless mistakes or unnecessary risks, and having a hard time resisting temptation. ADHD is very common, much more common than autism, with the estimate around 10% of children 3 to 17 years. And data have shown that it's associated with increased mortality and particularly accident and injury mortality. So the implications are that children with autism may be at increased risk for drowning and other injuries due to wandering behavior and symptoms of co-occurring conditions. And data to understand the potentially unique risk factors for injuries among children with autism are critical but lacking. And this information will be important to inform prevention efforts in the future.
Okay. Well, thank you, Sarah. And we're going to have time for questions after all the speakers talk. I do want to remind folks to put your questions in the Q&A throughout, though, as they arise, so we can keep, and we will get to them at the end. So our next speaker, again, is Shericka Harris, who will be talking to us about unintentional drowning deaths. So Shericka, back to you.
Good afternoon, everyone. Today I'll be talking about unintentional drowning deaths among children and adolescents with ASD in the U.S. 1999 to 2022. Next slide. So when looking at drowning in the United States for all ages, over 4,500 fatal drowning deaths and over 8,000 non-fatal drowning deaths occur each year. When looking at children less than 18, there are over 800 fatal drowning deaths and over 6,000 non-fatal drowning deaths each year. And drowning is the leading cause of death among children 1 to 4 years of age. Next slide. So drowning locations vary by age group. For infants less than 1, it typically occurs in bathtubs, children 1 to 4, home swimming pools, and people 15 and older, natural waters. Next slide. So for this slide, I won't present the stats since Sarah already presented that, but I would just want to reiterate that there's an increased drowning risk among children with ASD, and we don't know why children with ASD are more susceptible to drowning than others. Next slide. So I'm going to talk about some of the characteristics of unintentional drowning death in children with ASD. There was this one study that analyzed news articles in the US from January 2000 to May 2017. And in this study, there were 23 fatal unintentional drowning deaths for children 3 to 14 years old. And the most frequent drowning locations were ponds, followed by rivers and lakes that were in close proximity to the victim's home. And wandering led to most of the drownings, accounting for 74%. Next slide. So the objective of this study was to explore unintentional drowning deaths in the U.S. among children and adolescents, where ASD was identified as a contributing cause of death on the death certificate. Next slide. So for this study, we used data from the National Vital Statistics System for 1999 to 2022, and we included children and adolescents less than 20. The ICD-10 codes that we used for the study are listed on the slide, and we also calculated descriptive statistics. Next slide. So for our study, the total sample, there were 25,492 drowning deaths, and where ASD was listed as a contributing cause of death, there were 114 drownings, accounting for 0.4%. Next slide. So now I'm going to present some of the results from our study. So when we were looking at this compared by sex, where ASD was a contributing cause of death, males accounted for most drowning, representing 82.5%. And then in the total sample, males also represented most of the drownings, representing 73.9%. Next slide. So when looking at the drownings by age group, we found that children aged 5 to 9 accounted for almost half, 46.5% of the drowning deaths where ASD was listed as the contributing cause. When looking at the total sample, children 1 to 4 accounted for most of the deaths, 41.9%, followed by children aged 15 to 19 years old. Next slide. So when looking at the drowning deaths by census region, where ASD was a contributing factor, they most frequently occurred in the South, followed by the Midwest. And then when looking at the total sample, the drowning deaths most frequently occurred in the South, followed by the West. Next slide. So when looking at the drowning deaths by the water body type. So where ASD was a contributing cause of death, they most frequently occurred in natural waters, followed by bathtubs and ponds. But then when looking at the total sample for drowning deaths, we found that the drowning deaths most typically occurred in the pool, natural water. Next slide. So next, I'm going to talk about some of the limitations for our study. So diagnosis of ASD often occurs after age 4, and this may explain some of the higher percentages of drowning deaths occurring after age 4. And due to limitations with the death certificate data, the number of children and adolescents with ASD who fatally drown is likely to be underestimated in this study. And we also want to point out that this data may not capture all drownings among children with ASD, only those for which it was listed as a contributing cause. Next slide. So in summary, for this study, we found that children 5 to 9 years of age accounted for almost half of the drowning deaths, with ASD listed as a contributing cause on the death certificate. And most drowning deaths among children with ASD frequently occurred in natural waters, followed by bathtubs and swimming pools. Next slide. So next, I would talk about some of the drowning prevention methods that can be used. You can do things such as learning to swim and water safety, build and maintain fences, supervise closely, wear a life jacket, and avoid alcohol. Next slide. And some additional tactics, you can learn CPR, know the risks of natural water, use the buddy system, take precautions for medical conditions, and don't hyperventilate. For caregivers of kids with ASD, it is also important to be aware of the drowning risk and be extra vigilant when around water. Next slide. So I want to share that we have been working with community partners to improve swimming and water safety skills among children with ASD. So in 2023 through 24, we partnered with the YMCA to adapt a basic swimming and water safety skill training program for children with ASD. And the goal of this study was to increase access to swim lessons for children with ASD and to evaluate the swim skills generated through lesson delivery. Next slide. And so I will give an overview of our YMCA Autism Swim Skills Project. So with this project, we had 9 YMCA associations ranging in size from 1 community center to 20 centers. So each YMCA provided swim training to 50 youth with ASD, and there were 8 sessions. Each were 30 to 40 minutes with where they taught safety around water. And all lessons were taught by certified swim instructors who were provided with additional training and assessment tools to test their lessons. Pre and post swim skills assessment data is being collected on each child. And all local Y project leads have completed a survey about their experience working on this project and using the assessment tools. And our data collection and evaluation will be completed next Wednesday, July 31st. And we are really looking forward to the results of this study. Next slide. So I'm going to present some of the preliminary qualitative findings from our YMCA project. So the feedback and interest expressed by parents indicate a need for swim and water safety programs for children with ASD. A lot of the Ys reported that the demand was so high that they had to refuse people because each Y could only accept 50 kids. The program provided skill improvement for youth. The program provided an activity that families could enjoy together. And it was noted that more research is needed about the effectiveness of private lessons versus small or typical size group lessons. Next slide. And these are some of the references. Next slide. And I would like to thank my co-authors listed on the screen for their help with this study. Thank you.
Thanks, Shericka. And we are getting some questions in the Q&A, so please continue to add those. And I'm going to turn it over to Jarbing to talk about the burden of injury.
Thank you, Judy. So the title of our project is called The Burden of Injury in Autistic Children. So next slide, please. Thank you. So some background information, as we have already learned a lot from the previous speakers, that the injury is a leading cause of disability and fatality in children around the globe. In our country, CDC lists the injury as the #1 leading cause of death and non-fatal ED visits in children. Emerging research has suggested that injury poses a especially significant burden for autistic individuals in general. Next slide, please. Thank you. So autistic individuals are at higher risk of all kinds of injury-related incidents, including suicidal ideation, up to 66% more, suicidal attempts, up to 35% more, and ED visits related to self-inflicted injuries, about 500% more. More specifically, autistic adolescents under 15 years old were also found to be 3 times more likely to die from unintentional injury than the general population. So there are several gaps in the current literature. There is a lack of population-based approach to examine the impact of injury to autistic children from the full developmental spectrum. Little is known on the economic burden and its disparities incurred as a result of healthcare services costs associated with injuries across multiple payment sources in autistic children. So that kind of leads us to the present study that we aim to provide up-to-date national estimates of the health burden imposed by injuries on autistic children. We also want to examine disparities in injury-related medical seeking behavior and medical expenditures in autistic children. Finally, we'd like to develop precise and almost done, tailored interventional programs to reduce injury-related health and healthcare burden for this population. Next, please. So the methods we used is we're using about 22 years of data from the Medical Expenditure Panel Survey, which is sponsored by ARC. And the benefit of using this data set is that it has collected data from nationally representative cohorts of civilian non-institutionalized households, and it provides population-based national estimates of healthcare service utilizations. So now specific to this project, 3 types of MEMS data files were used in our analysis, the 20 years of full-year consolidated data files, medical condition files, and medical event files from the MEMS data set. There's a distinction between public freely available data set and also the restricted data set that can only be accessed mostly on site as the data centers in DC. So, and I will talk a little bit about that when we go to the next few slides. So look, we have a couple of variables of interest based on the study objectives. First is the outcome variables. We're interested in whether our autistic children had an incidence of injury. Secondly, we want to know if when the injury happens, is there an injury-related treatment event? Did they go to see the doctor after an injury? And thirdly, injury-related medical expenditures either paid out of pocket or by any type of insurance programs. We ascertained a lot of predictors available in the MEMS data set, including demographics information from both the children and the families. So we're going to put all of this in our regression analysis that you will see in the results section. Next, please. So a few words on the sample in our analysis. So because we covered 22 years of data sets. So we have used both the ICD-9 and 10 code fully specified, meaning we have to go to the DZ data center to access those restricted data files. And in the end, we had a sample size of 1,050 autistic children across all years combined. And on the right side, you will see a simple distribution of basic demographics across different levels in this sample. Next, please. So we have two sets of results, and one is the annualized national estimates, and I will focus on that in today's webinar presentation, and we'll have slides saved for the trend analysis available online after the webinar. So let's take a look at the overview of the annualized estimates. So from the sample size, we had estimated that nationally, there are about 439,000 autistic children, and among those, about 10% of them reported an injury incident during the interview period of the MEMS data collection. And for those autistic children who had an injury, most of them went to seek medical care after an injury. About a third of them were treated at ED, and much smaller number of them were treated inpatient or hospitalized. Although these two numbers are not exclusive of each other, they could be both seen at ED and later transferred to inpatient services. The bottom columns are for the injury-related medical expenditures per child on given year. So the total medical expenditure per child on the median level is $252, and most of which was paid by insurance programs. So as you can see, the out-of-pocket expenditure, the median level was 0, although the 95 confidence interval ranged from 0 all the way to $45. Next, please. So in the next few slides, I'm going to present a few charts to give us some visualization about the distribution of injuries across different categories. So this first chart is about how autistic children versus non-autistic children had different injury types. And from here, you can see on most categories, the two groups are similar to each other. The most significant difference occurs regarding open wounds injuries, where autistic children seem to have significantly more than non-autistic children. So that's something interesting and might have implications for injury prevention as well. Next, please. So regarding service types, so we had several categories: ambulatory, emergency department, hospital inpatient, home health, prescribed medicine. So across all those 5 categories, so we can say that autistic children after an injury, they are more likely to receive home health services and prescribed medicine services than non-autistic children. But on the other categories, non-autistic children are slightly more likely to receive those services, although the difference are not that significant. Next slide, please. So this slide presents the distribution across payment sources. So we had previously talked about out-of-pocket versus covered by insurance programs. So here is a little bit more detail. So it covers private insurance, family or out-of-pocket expenditures, Medicare, Medicaid, and other types of payment sources. And from here, you can see that autistic individuals, they're more likely to cover their healthcare service expenditures with Medicaid programs and non-autistic families, while they are less likely to utilize private insurance programs for covering the expenditure related to injury incidents. Next, please. So finally, this is the regression analysis. So we conducted multiple linear regressions as well as logistic regressions, depending on the type of the outcome. So for injury incidents, we can see the significant predictors are the age and the parental education and the geographic region. So children in the 10 to 14 years old are significantly less likely to have an injury compared to the reference group, which is 0 to 4 years old. And these are all autistic individuals. It does not include non-autistic individuals. In terms of parental education, so autistic individuals who have parents with college and higher education levels, they are more likely to have an injury compared to those who have parents with less than high school education levels. And children who live in the west region of the country are more likely than the northeast region to have an injury. In terms of medical seeking behavior, the significant predictors are race and parental marriage status. So Black autistic children are found less likely to go to see a doctor after an injury than the white reference group, and children who live with single parents, they are more likely to seek medical care after an injury than those children who live with both parents. And finally, about medical expenditure, we found that the only significant predictor is the perceived mental health. So children with poor perceived mental health were found to be much more likely to have higher levels of medical expenditure related to injury incidents than those who report having excellent perceived mental health. Next, please. So in summary, autistic children are at, in general, at comparable risk of injury as the general population. With that being said, the limitation of this data set is that we don't know what kind of injury they have. So although average out, it seems comparable between autistic and non-autistic, we do know that autistic individuals tend to suffer more open wound injuries. They're more likely to be hospitalized after an injury. They receive more home health and prescribed medicine for injuries, and they use Medicaid, Medicare, and pay out of pocket for injury treatment. So kind of implication from this finding is that the next study logically is that we want to look at the detailed injury mechanism and injury intents among autistic individuals, and perhaps compare them with non-autistic populations as well to find why this is the case and whether autistic children are at particular higher risks in certain injury mechanism or injury intents than non-autistic counterparts. Next slide, please. In terms of predictors of burden of injury, we found age, parental education, and the geographic regions are related to injury risk. Race and parental marriage status related to medical seeking behavior, and perceived mental health related to medical expenditures. And from the analysis that due to time constraints, we didn't present here about the trend analysis from 2000 to 2021, we found that the increase of autistic children among general population, as we have seen from the previous presenters as well, increase of injury-related economic burden for healthcare services, and injury rate and healthcare service utilization, they do fluctuate over time, and especially during different societal events that happens, including during the pandemic area, that these kind of statistics change from time to time. Next, please. So this is the final slide. So I just want to thank all the collaborators at UMass Lowell and external institutions to collaborate on this project. We have an amazing community advisory board who have advised us from the beginning of designing this project into interpretation of the statistical results. And also thank the HRSA Autism Secondary Data Analysis Research Program for funding this project. Thank you very much.
Thank you, Jeremy. So again, I've seen lots of questions come in. I think we're now ready to do some of our questions and answers, and I think everybody's going to come back on the screen in a minute. Right, and I know some of our presenters have already been typing in some answers as we've been going along. So I'm going to start with, I guess, coming in order. And I think the first one is to you, Sarah, that came in during your presentation, though if others want to chime in, you are certainly welcome. It said, do we have any direct evidence that rising rates of autism in Black and Latinx children are actually due to better access to diagnosis, or is that an indirect hypothesis?
It's a great question. I think we would say it's an indirect hypothesis, as there's no other, we know that there have been increasing efforts to make screening more universal and access to diagnostic services easier for people across, for all children, basically. And there's really very little systematic data collected on actual screening and testing practices. So I would say that is more of an indirect conclusion from the data.
Okay, thank you. All right, there were a couple that came in around drowning and swimming and teaching kids to swim. So Shericka, I'm going to try and jump through and group them for you. The first one was, is it more difficult to teach autistic children to learn how to swim in order to prevent drowning risk?
I think it depends on the child. I know with this current study, we had monthly calls with the Ys, and they indicated that for some of the children, it was the group lessons worked for them. And then for some children, they had to provide more one-on-one attention. So I think it depends on the level of the child, but there was success with the children, depending on which method they provided.
Okay, thank you. And then, do you have the adaptive swim curriculum or resources that were provided to the YMCA to share?
So those resources aren't available to share now. I'm going to reach out to the Y and see if they are willing to share these resources. I think they are proprietary to the Y, but they may be willing to share with, I know I saw a question in the chat where they said some communities may not have access to a Y. So I'm sure they would probably be willing to share those materials.
Great, thank you. Mm-hmm. And that was the next question about whether they were proprietary or not. So one more about drowning and swim lessons, and then we'll switch topics a little bit if we can. It says, I look forward to the results of the study about Y swim lessons. Is there currently a list that can be accessed by caregivers and contains locations, instructors with autism experience? Many families seek swim lessons, but report poor fit between instructors and children.
Yes, for the YMCA, I know you can reach out to your local Y to see if they provide adaptive swim lessons. For this study, it was in 9 locations, and I do have a list of the locations so I can read it. So our study was in Augusta, Georgia, Austin, Texas, Charlotte, North Carolina, Dallas. I think it's Pocomoke, Massachusetts. I may not be pronouncing that correctly. Marshalltown, Iowa, Richmond, Virginia, South Palm Beach County, Florida, and Superior, California. And we hope to expand to more Ys. This is the pilot, so we're hoping to expand to more Ys next year.
Great. All right, let me just scroll down a little bit here. So there's a question about data. Is there data on kids being misdiagnosed, meaning that autism spectrum disorder is missed and the child is diagnosed as having something else?
This is going to be less of a data-driven answer, but I think given the complexity of diagnosing autism, I think that would have to be the case. The degree to which that occurs, I think would be challenging to quantify, but certainly I think it's possible.
Sorry, there's a lot of questions, so lots of stuff for folks that want to know about. So I'm just going to read through them. Can some of the self-harming behavior in children with autism be characterized as the child stimming? In other words, biting themselves, hitting themselves.
I don't know the answer to that. I think that would be a good question for a clinician. There certainly are stimming behaviors in people with autism that can help with kind of a self-regulation mechanism. So I think whereas previously there may have been discouragement from engaging in those behaviors, I think that the current philosophy is that as long as it's not self-injurious or injurious to other people, that those are actually very helpful behaviors. But in terms of whether self-injury could be considered stimming, I'm not sure.
Thank you. And then several questions related to elopement. One person wants to know, is there tracking devices that are recommended for children who elope? And do you have any guidelines or recommendations to support families with identifying tracking options?
So I think the short answer would be no, just in terms of our role in recommending those kinds of supports and services. But I think you can go to CDC's website to find kind of recommendations for organizations that might be able to help. One thing that keeps going through my head in terms of autism and the best way to support children with certain challenging behaviors is most clinicians who work with people with autism will say, if you've met one person with autism, you've met one person with autism, because the supports and services that individuals need are so specific. So I think there's not one blanket recommendation that's going to work best for every child who has that issue. So I think kind of working comprehensively with their care team is going to be the best way to move forward.
Yarving, I think this one is for you. I'm from the child welfare system, and I think you covered this a little bit in saying what your next steps were, but for your study. But I'm from the child welfare system, and I'm wondering if there are findings/data that drills down to cause. Was this, and which I said I think is part of your next one, was this abuse by a parent, provider, lack of supervision, lack of parenting or understanding of the child behaviors or needs based on specific autism diagnosis? And is there actually data regarding lack of resources or services that may lead to injury based on demographics?
Thank you for asking this question. Yes, so I would say, like, from the data we analyze right now from the MEMS data set, we would not be able to know like what's the cause of those injuries, as it was not available in that data set. But I do know there are several other data sets, including like the National Emergency Department System data set, and they have specific variables that addresses the injury mechanism and whether it's unintentional injury or it's self-harm injury or maybe it's assault-related injuries. So by looking at those data set we'll be able to tell what kind of distribution of injury mechanism and intents in autistic children. With that being said, there are also differences between those data sets, like the MEMS data set is population-based, but those ED data sets, they will be based on a hospital data set, so they are sampled differently. So the representativeness of the conclusions will need caution when we interpret the findings, but I totally with you that it's very important to understand the cause of those injuries and to understand how those different reasons for injuries, including abusive behaviors and maybe potential behaviors or services provided by care providers or parental supervisions might have contributed to injuries in autistic children.
Yeah. Do we have any information on autism and other injury mechanisms, like related back to mechanisms, but do we know anything about autism and other injuries like car crashes, overdoses, driving? You mentioned suicide risk and suicide ideation in one of your background slides. Anything you guys can share with our audience?
So my reading of the literature is many studies have focused on self-inflicted injuries in autistic children, not so much on unintentional injuries, but I do agree that these are equally important topics to study. One other area that has drawn emerging attention is how autistic children might, because of their unique communication styles, they might have different ways to interact with law enforcement personnel, and which may contribute to certain conflicting behaviors and may result in injuries as well. So that's also an area of interest, both in real daily life and as well as in kind of scientific interest. So there are certainly a lot of things that we have yet to understand, and which speaks to, I think, the importance of this webinar and to start a new generation of more innovative research in this area.
And I did want to, jump in on this one too. I think one of the challenges in terms of using a lot of the available data sets, and I'll use the death certificate, that work that Shericka described a little bit, is that autism isn't going to be noted necessarily. And in fact, we're finding we're working on a paper where ADAM data were linked to death certificate data from the NDI, and almost never is autism on the death certificate because it's rarely considered a contributing cause of death. I think drowning because of elopement would be one of the few times where it would be included. But in a car crash, if it's not thought that the autism contributed to it, like if they were a passenger, it's not going to be noted. So it's going to be, if you're not starting with a population of people with autism, it's going to be really challenging to get at these types of statistics because it's so often not information that's captured in our existing systems.
Okay, thank you. And we actually had an attendee respond to one of the questions around tracking, that there are new shoe inserts which accommodate Apple AirTags that are hidden and easy to track and affordable. Oops, I should have hit answer live, so let me read that again. For the tracking question, again, new shoe inserts that accommodate AirTags. that are easy and affordable. Right. We still have about 4 more minutes, so let me just try and cover a few more questions. There's a lot here. Are there any parent caregiver educational materials available for injury prevention? Are there any parent caregiver educational materials available for injury prevention among children with autism? These materials could be available in clinical settings as well as the community. And Sarah, you previously mentioned some on the CDC website.
I don't know that those are specifically for elopement. And I'm not sure if Shericka,
Yeah.
you know of any materials. I guess that would be specific to drowning.
Yeah, in the chat earlier, I think it was we posted some drowning and drowning prevention resources. So in some of the resources, they do talk about autism and elopement and about establishing a safety toolkit, a plan, and stuff like that. So some of the resources, there are some resources out there that are available.
Yeah, and those will be shared when the slides are posted. Okay. All right. So this is more of a comment than a question, but it said, although girls and boys should have the same opportunity to be identified, they simply don't. Often pediatricians don't recognize female autistic traits because of high masking and higher social capabilities compared to male. So this person would love to see more studies on the qualitative analysis of diagnosing experience, delayed diagnosis, misdiagnosis, etc., from the perspective of parents and guardians. So I'm wondering if any of you have anything you want to add about diagnosing autism.
I can add that because of exactly the issues that are brought up in this question or comment, one of the way that Adam ascertains autism is based on diagnosis. So it's not trying to find some kind of underlying ground truth because of the complexity of that. It's trying to say, here are the number of people in these communities who are diagnosed, which informs difference, kind of shows differences geographically and can allow identification of factors that are related with higher or lower identifications. But I think so a lot of our work is not focused on kind of the subtleties of the differences in the way that autism can present in girls and boys. However, it is a major focus of the field as a whole. So I think there are people trying to look at that issue.
All right. We are at 2:58. I hate to say it. We are at the end of what we have, and we have so many more questions. I know some of our panelists are typing some responses, and I'm sorry we couldn't get to all of them, but I know we have some resources we're going to share. And I also want to thank folks for their participation. Thank you for all these really great questions. And thank our presenters, give them a big hand for sharing their time and their knowledge with us today. And I just want to ask folks that you'll get an evaluation that's up there. If we can please complete your evaluation of today's session. Again, the link is on the slide. So with that, I think we are ready to finish. Again, thank you all. And again, the link to the evaluation is in the webinar chat as well. So thank you all again. Hope this was helpful. I know I learned a lot, and thank you again to the presenters. Bye.